about crystal ball gazing as regards refractive surgery. And is everything all right?
Yes, sir. The slides are visible and your audio is audible.
Perfect, sir. Perfect, sir.
So, as we look at refractive surgery, if we look, I think things change so very fast. Earlier, it was just cataract surgery, and then we looked at retina, glaucoma, etc. But then came in refractive surgery with a big bang. So, over the years after cataract surgery, the next commonly performed surgery is refractive. But over the last, I would say 3-4 years now, it's the intravitreal injections which are coming number one, maybe more than cataract surgery also. So things will keep on evolving. But just to say that refractive surgery will always have a space, because whenever a person has any encumbrance, at that particular time, a person wants to get rid of the encumbrance, and refractive surgery is really giving you the outcomes that a person wants to have, the freedom in life. So what is very, very important, let me just speak from the pre-operative workup. I think pre-operative workup, there are still these lacunae where we can't say as to whether a person is fit for the procedure or is unfit for the procedure. There are still lots and lots of nomograms, lots of equipment that is coming, but one unified equipment is something that I feel would be the future, where you have the biomechanics, you have the topography, you have the outcomes, you have the regression analysis, you have whatever it may take. And it should also be able to tell us that the epithelium mapping that is also coming in the OCT has to be looked up. Basically, whenever you are looking at refractive surgery, you are doing it on a normal cornea or in a normal person, except for the refractive error that the person is having. So the first principle is that there should be no harm that should come on to the patient. So that is the future, where I will say that biomechanics, tomography, epithelial mapping, post-operative outcome, anesthesia, etc. Somebody is so all of this will come into one equipment. I think that is the future, where you can just scan and say that this person is fit for refractive surgery and what type of refractive surgery. I think, and the present thing, whether PRK preserves the biomechanical strength better, or Smile does it, or LASIK or iLASIK. I think that is what the future is, and that is what we demand from the manufacturers, that it should be a simplified formula where we don't have people of great expertise to tell us. So it will be simplified, and that is what is going to come. Artificial intelligence is therefore going to be very, very important, where data is going to be the king, and we have to see as to how the patient has progressed, under what category the patient was, and what procedure was done, and the algorithms will need to be done. So that is the first and the foremost important thing, is that the pre-operative selection criteria for a person being fit or unfit would be there. Now, when the second thing is that when we came, there was a lot of talk about eagle vision, there was wave scan, there was the zyoptics, etc. that came, supervision. So actually, it didn't come to fruition. So, but there are a lot of work that is going on, and I feel that this is again going to be something where the ability of a person to see the contrast diminution which is there, or the quality of vision diminution which is there, those would be taken care of by getting the proper maps of the cornea, and how do you translate it onto the cornea, whether it be on the Smile platform or whether it be on the Excimer platform. So I think that is something which should be with us over the next couple of years, which is there. Now, a lot of work from the India. We are proud of Rohit Shetty and his group, who are talking about genomes, ectasia as to what it is, and the different genomic the locus which are there, which have been identified in patients who could be having keratoconus, etc. So I think this again would be the interplay, and tomorrow the samples that maybe people are collecting, that can help in looking at whether a person would be a suitable candidate or not for that. Whether the requirement is in conjunction with anti-inflammatory or gene therapy or localized, that will be the thing. Now, my crystal gazing as it is, I think this has moved on, and it is moving, that the flap would be lost in the past. And that is something that over the decade, there is a gradual shift from the flap-based keratorefractive. The blade procedure has in India still a position because of the economics that is there, but the femto lasers have really come in. And what is important is that the smaller the incision is something which is very good. And all the companies, I would say all the companies who are in the refractive business are going on to the flapless condition, which is there. And my personal thought is that if I do a crystal gazing, I am sure that the flaps would be dead and buried over the next 5 to 7 years. And there would be customized stromal removal of the tissue, as also for hyperopia, missed astigmatism, everything which is there. You could also look at the implants or the tissue that is being taken. So the smile lenticule or the lenticule that is coming from the corneal stroma, you could have the intrastromal lenticular implantation for treating hyperopia or mild keratoconus. The cross-linking technique that you can have, where you can use this, or when you are looking at the adjusted fluence that could be there. These tissues could be used for patch graft. They could also be used for presbyopia correction, and would obviously research on corneal tissue which is there. So this is the pearl, where a small tissue is put in the center for presbyopic. Tailored stromal expansion for ultra thin corneas is another thing which can be done. Now the latest that has been reported is by Pavel Sodulka, is that if a person is having high astigmatism, they are just doing a lenticule and they are just rotating the lenticule to change the axis and to get the astigmatism off. So that could be another thing where you could remodel the same cornea of a same individual without actually removing the lenticule, but just rotating it to a particular position, or even doing intrastromal ablation for that particular tissue which is there. Obviously, as I told you, not having ectasia is something, so there will be nomograms which will come for the extra procedure as to the combination which you have, and the cornea which is being weakened, which we all know would obviously be taken care of, whether we are doing a cross-linking or something better than that is there. The cross-linking would obviously also give you advantage as regards the reduction in the regression which can happen in hyperopia, etc. And this is just to show you that there is a demarcation line that comes after the extra procedure, whether it be in the LASIK or in the smile. But the smile procedure or the PRK extra, that gives you much better outcomes than if you do it in a LASIK. So this is a simple procedure, just to show you that we are doing it pretty often. This is the smile procedure that has been done. Once the lenticule has been removed from the smile procedure, we will just go ahead, remove the lenticule, and then there will be the riboflavin that will put, which will be based. So there are different types of riboflavins which will keep on evolving, and then the adjusted fluence to get as to what is the normal and finish of the procedure. I would, if I need to do crystal ball glazing, what is very, very important in refractive surgery, whether it be a cornea-based procedure or a lens-based procedure, I think the next frontier that is going to be conquered would be the presbyopia. And my particular thought process is that it is going to be a lens-based procedure rather than a cornea-based procedure that is going to come. But more and more work will come. And once you have this, even the patients who have earlier had a cataract surgery or any other form of refractive surgery, we can go in with, say, phakic implants or with the presbyopic correction. That is going to be something which is very, very important. Now, the other important thing, which is the role of pharmacological agents, which are to reverse presbyopia, I think that may also see working on the lens, whether by putting small cuts on by the femtolaser intralenticularly or some other method. But future does the maximum promise that holds, and where you get a huge population of people who would be wanting this treatment, is to take care of the presbyopia that is there. And this is just the EVO06, which is the lipoic acid choline, which can be working to help you. These enzymes within the lens fiber cells chemically reduce lipoic acid to active form of dihydrolipoic, and that causes a change in the lens, and that is there. And the final thing that I feel it could be, again, the cataract surgery would be equal to refractive surgery. As it is, we are looking at cataract surgery with better IOL power calculations, with better techniques, with toric lenses, with the trifocal lenses, or with the continuous range of vision lenses, and lenses which are achromatic today. I think the optics and the vision is going to improve, where we can have absolutely predictable results. And even if there is a residual refractive error that is there, that can be corrected by light ablative methods, or by doing what is the refractive index shaping that can happen. And this concept of refractive index shaping, or to have the lyric, which is the extrapolated for keratorefractive surgery in the form of laser induced refractive index change. So even if there is an error which is there and your person is not happy with the refractive error, there will be methodologies to fix, to freeze the change in the refractive error that is there on the cornea or on the lens which is there, and that is something that is going to help us go on to the uh, goal of emetropia, or even customizing the outcomes for each and every individual as to his likes and all. And one more thing I will say is that there could be a possibility which should be there, that one can actually extrapolate to a person that this is how your vision is going to be after the procedure, and what do you want exactly in that particular domain, and he can pick and choose that this is what I want as the end result. So that is what it is. It is as if a customized solution for each eye, and that is going to be the future or refractive surgery, where higher order abrasions, lower order abrasions, the entire profile can be done as per the requirement of an individual. So in a nutshell, I would wish to say that the current generation of refractive surgeons experience the unfortunate burden of dissatisfied patient that is going to reduce over time, and the perfect refractive model starting from the pre-operative to the operative and fixing it in the post-operative period is going to be there, with reduction or elimination of complications that is there. So I feel that refractive surgery is one of the exciting fields where the maximum kind of revolution is going to come over the years, that is that we will see, and maybe the next one decade will hold great promise for newer outcomes for refractive surgery. Thank you very much for your kind attention.
Thank you so much, sir. It was a delight to listen to you.
Thank you, Dr. Mahipal, sir, for giving us that wonderful overview. And I think KP, that is so amazing.
The level of commitment by sir is he was part of every meeting and immediately plugged in and gave such a wonderful talk, eye opener for everybody.
Sir, I would again request you for just a 30-second message to our audience, because these are the course is basically targeted to people who are new to the refractive surgery. They want to start, or maybe they are yet to establish. As a president, as a chairman, with your vast empty years of experience, sir, just few keywords to encourage them.
Yeah, so Sonu, what I have to say is that it should not be being a refractive surgeon is not a time pass thing. If you are into refractive surgery, you should have everything under the horizon that you can do. It is not that you have to fit one procedure onto every eye. What is most important is that what is the eye demanding? What would be the procedure that is going to give the best outcomes? And if there is a problem, you should be able to handle. At times, the trivialization of refractive surgery has happened, wherein people who are not adept to dealing with refractive surgery, or they do not have access to a lot of techniques and armamentarium techniques, nor can they manage the complications, take over refractive surgery, and that can cause grief. So you have to understand right from the beginning regarding the cornea, regarding the biomechanics, regarding the topography, regarding pre-operative evaluation, how the procedure is done, if something goes wrong, how to take it, and what procedure has to be done, and be abreast to all the new techniques and technologies that are happening. It is not a one-time thing that I have purchased one machine and that is about it. I think there are revolutions that are happening. Take that as your passion. Don't take that as a pastime to make money. And if you are doing that, you will come to grief. You have to actually be involved and be known as a refractive surgeon. Unfortunately, refractive surgery is not available in a lot of medical colleges, and therefore people are not exposed to it. I think scientific committee is doing a great duty. You are also doing a great job, where you are exposing the people as to where refractive surgery is and what is the acumen that you need to be masters in refractive surgery.
Thank you so much. Sir. Any comments from Lahane sir?
Lahane sir.
I think good afternoon everybody. What Mahipal sir was saying, I think the refractive surgery really, I think it was an eye opener, and all those who are the new refractive surgeons, I think they might go ahead, as the Mahipal sir was saying that Rohit Shetty sir is doing this. So I think the Indian scientists should come forward. See what happens. We do whatever the Western people are doing, but people like Mahipal, people like Amar Agrawal, people like the Rohit, see, they are doing some indigenous research. So we want such type of thing should happen in India also, and they should follow us. So that Mahipal is one of them. The people will follow him. So I'm very happy that Mahipal sir, though he was in the very busy schedule, he joined. And thank you, Dr. Mahipal.